Please be seated. I open this public session of the Doctoral Examination Committee of the Faculty of Behavioral and Movement Sciences by affirming that from our Christian origins to the present day, we practice science with a sense of wonder and inspired by fundamental values. Prior to the examination, I invite the candidate to give a brief explanation of the research on which the thesis is based. The floor is yours.
Dear Rector, dear audience, thank you for attending the defense of my PhD thesis titled Barriers and Opportunities to Combat Sarcopenia in Geriatric Rehabilitation. In the next 10 minutes, I will summarize its key findings. Let's start by having a look at the journey of geriatric rehabilitation patients. Each year in the Netherlands, 500,000 older adults are hospitalized. Of these, 1 out of 10 needs rehabilitation. This is provided by a multidisciplinary team, including physicians, nurses, physiotherapists, and dietitians, among others, who work together to promote recovery. The primary goal is to improve independent functioning, including mobility and activities of daily living, and enhance quality of life. Thanks to interventions, namely exercise and nutrition, 8 out of 10 patients can then return home. Central to this recovery is muscle health. Muscle typically starts to decline around 30, 40 years old and accelerates after 70, especially in the case of disease. And this decline can progress to sarcopenia, defined by low muscle strength and low muscle mass. And as you can see on the picture, sarcopenia involves the gradual replacement of muscle by fat tissue. This is a widespread problem, especially with our increasingly sedentary lifestyle and sometimes poor diets. We know that in older adults, it negatively affects life expectancy. The aims of my thesis were fourfold. The first one was to assess the characteristics of geriatric rehabilitation. The second one, to assess sarcopenia awareness and implementation in practice. The third one, to evaluate the feasibility of sarcopenia diagnosis in practice. And the third one, to assess the feasibility and effectiveness of sarcopenia interventions. Let's dig into the results. We have seen that geriatric rehabilitation patients widely differ in their characteristics. If we take 2 fictive typical examples of patients admitted after a hip fracture, we can have John on the left, 70 years old, who is already quite mobile at admission. He lives alone quite independently despite suffering from diabetes and hypertension. On the right, we have Hannah, 80 years old. She has a lot of pain at admission and is unable to walk. Nurses have also noticed that her cognition is quite poor and she lacks appetite. She lives with her husband, who was already doing a lot for her before she broke her hip. So as you can imagine, although John and Hannah were admitted for the same reason, their rehabilitation trajectory will look quite different. In our study, 1 out of 2 patients were malnourished. This means they had a poor nutritional intake, had lost some weight unintentionally, amongst other factors. Also, 1 out of 4 suffered from sarcopenia, so described as low muscle strength and low muscle mass. We also found that patients who were malnourished were twice more likely to also have sarcopenia. During admission, patients with malnutrition and sarcopenia received less physiotherapy than their peers. Their weight did not change, and they gained a bit of muscle mass, but not that much. When looking at awareness, only 3% of the 200 patients that filled in our survey knew what sarcopenia is. But when explaining it, 56% reported they would be willing to start taking a high-protein drink or an oral nutritional supplement, and 67% reported to be willing to start with resistance training if sarcopenia was to be diagnosed and treatment was proposed. But they also named a lot of barriers, including a dislike of high-protein products, doubt about effectiveness of this treatment, having a lot of other health issues, and the intensity of resistance exercise training. In 500 healthcare professionals, 84% knew what sarcopenia is, and 90% reported to be diagnosing it in practice. But when we asked how, only 3% did so correctly by measuring the right measures of muscle strength and muscle mass and with the right equipment. They also reported quite some barriers, including a lack of knowledge, a lack of access to the right equipment, a lack of time, and a lack of protocols. But in our studies, muscle strength and muscle mass assessment appear to be quite feasible. Hand grip strength could be measured in 93% of patients, requiring them to squeeze a handheld device as strong as they could for a few seconds. And we also saw that this was more adequate than performing the chair stand test, because it's quite difficult for patients to raise from a chair without their hands at admission. Also, muscle mass could be measured in 77%, requiring patients to lay down still for a few minutes with electrodes placed on their hands and feet. And in less than 10%, this measurement could not be performed because of a contraindication, that is having a pacemaker or a patient refusing. Finally, we assessed the feasibility and effectiveness of a sarcopenia intervention. And for this, we recruited 80 patients at admission with low muscle strength, and we divided them into two groups. One group received a sarcopenia intervention, namely a high-protein drink or oral nutritional supplements twice a day, and resistance exercise training 3 times a week for 13 weeks. And the other group, the control group, received usual care. And we looked at adherence, namely how well patients could follow this intervention. And adherence was good for the high-protein drink in 1 out of 2 participants, and for resistance training in 1 out of 3 participants. The main barriers against good adherence were a lack of appetite, a dislike of the protein drink, refusal to exercise, and having difficulty to travel back to the rehabilitation center after discharge. But we saw positive, encouraging results in the group that had a good adherence to the intervention, so that the ones that could follow it well. Both groups did not show improvement in muscle mass, but they did improve during the 13 weeks in hand grip strength, chair stand test, and walking ability. And the group that had a good adherence to the intervention did better in those measures compared to the control group. In conclusion, sarcopenia plays an important role in the journey of geriatric rehabilitation patients, but they are not aware of it. And although sarcopenia diagnosis with muscle strength and muscle mass assessments appear to be feasible, it is poorly implemented in practice due to a lack of time, a lack of knowledge, and a lack of equipment. And for this, we need care organizations, researchers, and insurers to sit together to solve this. And also for interventions to work, we need to have a better adherence to them. And for this, we also need better knowledge amongst the general population. Thank you for your attention.